There's a lot of talk about male fertility declining in countries like the USA, where we are. Is that accurate?
That's a great question. We think it is accurate. So it all started when a couple of years ago, we had a couple of studies showing a major decline in the quality and quality of the sperm over the last 50 years in developed countries. So there was a big meta-analysis taking into account different studies, different smaller studies, and they showed a 50% reduction in this quality and quantity of the sperm. So when the study was published, it got a lot of attention and people started talking about, are we doomed? Is fertility declining? Are we going to be able to have kids, biological kids, families? So all of this started from basically these type of studies. Some people are very pessimistic, saying that this is not very accurate because we have evolved in the way we diagnose diseases and we have better ways of measuring them. We are better at measuring the semen parameters.
So we might be seeing things that we previously couldn't see.
Correct. So maybe there was a small decline, but now we're seeing it and we're just talking about it. Most people are still thinking that there is some tendency, the trend is there is a decline because of multiple factors. And we accept that as physicians in the scientific communities.
And is it fair to say that semen health is synonymous with fertility, or is fertility more than just semen health when it comes to men?
This is a complicated part in fertility. We don't have a single indicator that would accurately predict fertility. So semen parameters, we call it a proxy test for fertility potential. So if you have a good semen parameter, it doesn't guarantee you to have biological kids and fertilization. Same thing, if you have lower semen parameter, you might be still able to have biological kids. So I have a lot of patients in my practice with normal semen parameters struggling with infertility. On the other hand, we have people with lower semen parameters that got pregnant naturally with no problems. So it's just a tool that we have. Unfortunately, we don't have a better tool than that would predict this fertility potential. Like, how likely are you to succeed at natural conception?
So people are having less kids today.
Correct.
In developed countries.
Correct.
And that could be explained by biological reasons, but it also could be changes in the way we live and social norms and social circumstances.
Correct. I think the evolution of our culture and society have led us to deprioritize biological kids as the number one priority. Probably 20, 30 years ago, having a kid was the ultimate goal of having a family or being in a couple. Now, things have changed. We have some cultural changes and shifts in the mentality of people. So having biological kids and building a family is important. It's not as important as it used to. Add to that the factor that it's getting harder to biologically and medically conceive. So these two factors are leading to the fact that people are having less kids.
So it's getting harder to conceive biologically. What kind of percentage of that do you think is driven by male infertility versus female infertility?
That's a quick question. It's the biggest misconception we're dealing with, is that fertility is a female problem. We have the problem. Men are responsible for 50% of the infertility cases in a couple.
50%.
50%. So 1/3 of infertile couple are female factor, meaning that the female partner has some problem with the quality of eggs or some hormonal imbalances. 1/3 is just pure male factor, and the other third is a combined male and female factor. So we're 50% of the problem, which should be 50% of the solution.
I think that will come as a shock to me.
It is not to you. It's to every single patient and people in society. Men, they don't want to admit that there might be a problem with their fertility because historically, fertility has been linked to virility. Like if you're fertile in the man's head, and because we live in a society that's misogynist and sexist, it's linked to how virile you are, how sexual you are. So people didn't want to talk about problem with the fertility because for them, this is a problem with masculinity, with manhood.
But also presumably from an evolutionary perspective, how attractive you are or sought after you are from the opposite sex.
Correct. So historically and by evolution, the role of a man is to procreate. So if people start thinking that we have a problem with procreation, and this was in your deep mind, this is the reason of existence. So this is why this subject was a taboo over the years. And just recently, over the next 5 to 10 years, I would say, people started talking more and more. There was more awareness, more studies, and people are asking more questions. We're not there yet.
Well, it was taboo because men didn't want to consider that they could be part of the problem.
100%. They were just like, we're not the problem. We cannot be the problem. Like we're able to sexually perform. We're virile. We're like functional. And they assume that this is related to fertility, which is not the case.
Right.
That
So
they
you
can be independent.
You can have normal erectile function. You can ejaculate, etc., but be infertile.
100%.
Without knowing it.
Without knowing it.
And what does that mean, being infertile?
This is a good question. So 1/6 of couples around the world are struggling with infertility, meaning that 2 individuals trying to conceive, let's say naturally, and they're unable to do that. Previous definitions had a time tag over this process. The definition of the American Urological Association said a couple trying to conceive for 12 months that are unsuccessful are infertile. Now, the last 2 years, they've changed this definition, and they're just making it more culturally appropriate. Like any couple or an individual, whether a cisgender, transgender, gay couple, trying to conceive and are unable to, regardless of the timeline, can be considered as infertile. And thus we have an earlier diagnostic and intervention timeline for those people.
And at a high level, because we'll probably double click on some of these, what would some of the top reasons or explanations for male infertility be today?
So you have to think about 2 factors, those you can control and those that are out of your control. So the first group, environmental exposures, lifestyle, age, and infection, mainly sexually transmitted disease, are something that you can control, like something you can modify, right? Versus the other, like genetic problems, medical condition, physiological condition, medications, are probably something a bit harder for you to change. So these 2 categories can lead to male infertility.
And if you were to kind of look at all male infertility as an umbrella, what percentage of that would you say is treatable? Like if everyone came to see you as a urologist that specializes in this, out of every 100 men that come in and present with infertility, how many of them can kind of reverse that and be able to conceive?
So we have a very high success rate of treatable male fertility. There is only probably 20% of men that have fertility problem that we cannot treat, because either they have condition that we don't have the technology to treat, or we have something that called unexplained infertility. They're normal, but then for some reason, we don't know why yet, they're not able to fertilize an egg. And these are a small percentage of the majority of men. Most men who come to the clinic, we have an algorithm of medical testing, diagnostic workout, and imaging modalities that we do to try to see what's going wrong in their bodies and try to help them. And more than 60% of them are able to have kids and biological families in the future.
And you mentioned before that you can test your semen, which we'll come to.
Correct.
Within this conversation, or at least I hope we do. And it could come back and show that all the parameters are normal, yet you're still having difficulty fertilizing an egg. How common is that?
All right. It is not super common, but it's there. There is this, again, condition called unexplained infertility, whereby you're normal, your partner is normal, but still the process of an egg being fertilized by the sperm is not happening for some reason. At this point in 2025, we don't have the tools to know why, but things are coming. This has to do with the genetic and epigenetic formation of the sperm and the egg. And we have to go into a deeper layer to understand that. Most likely it's going to happen within the next, hopefully, 10 years or so, with adequate investment in research and development of the field.
I mentioned that you're a urologist.
Correct.
And I know for myself, this whole space gets a little confusing because you have endocrinologists, you have gynecologists who as I understand it, specialize in fertility for females.
Correct.
Then you have urologists that, as the name suggests, specialize in the urinary tract, but then also specialize in male fertility.
Exactly.
Is that how it works?
Yeah. So within urology, we have different subspecialties. We have urologists who are treating stones, urologists who are treating cancer, like bladder cancer, kidney cancer, or prostate cancer. We have pediatric urologists dealing with kids and problem in urology with kids. And then you have male infertility, men's health, sexual medicine, which is a separate subspecialty. And this is what I did. So I did like a fellowship in male fertility, men's health, sexual medicine, testosterone replacement therapy. And I mostly deal with patients who are affected with these conditions.
So what's that training look like? How long does it take to become a urologist that's specialized in that?
7 years of medical school and then 6 years of urology to graduate as a urologist. And then personally, I did a fellowship in male fertility in Chicago, and then another fellowship in men's health and sexual medicine. So yeah, around 15 years.
Right. It's a long path.
Yeah.
Yeah. And I think you mentioned that you fly straight back to Ohio.
Correct.
Tonight, and then tomorrow you see 40
It's a busy
patients.
clinic. Which is good because men traditionally and historically had very bad healthcare seeking behavior. Like men many years ago thought they don't have any medical problem. They usually, a lot of studies are showing that men delay their care. They're not compliant with the medication they're prescribed. They don't see a provider unless it's too late. And most of the health outcome is extremely bad if you compare survival, overall health of male versus female. So there is something called a gender gap in healthcare, just because we think that we're invincible. Like men don't just go to the doctor to check themselves or like to be proactive. They just go if there's something wrong and they want to fix it. And usually it's too late. So having more younger population and patients coming to see me is a good thing for me. It means that society is trying to change.
Right, the tide's turning.
Correct.
I mean, there's still accessibility issues for a lot of people, but we're seeing some progress.
Correct.
Are 100% of the patients that come to see you coming with fertility-related issues?
So some are just for general urology, some urine problems, some stones, cancer. The other half are people either trying to conceive but are unable to, or they're just interested in their fertility potential. So we have a group or a persona of patients. They're just interested. They're like young, they know, they read, they're up to date on the scientific papers and publications, and they understand the fact that the earlier intervene, the better the outcome is going to be. So they just come to my clinic and say, you know what, we're not in any relationship, we're not trying to conceive, we just want to test our fertility potential. And we do a lot of stuff to try to understand if there's a problem. And then once we find a problem, then we intervene before they're actually trying to conceive, which would be the most efficient way of doing it.
Do you have any kind of case studies of strange or tricky presentations, or perhaps things that you see regularly that patients think are strange or weird but are actually common?
I mean, we have a lot of misconception around fertility, around sexual function. So we have patients coming and asking a lot of questions that are very personal. So you always have to establish this trust between the patient and the doctor, because they need to open up. Then you need to understand why they're asking these questions. Usually they ask a question and there's like a lot of baggage behind this question. So it's a lot of misconceptions and myth about, again, sexual function, fertility. People are like, yeah, we're having sex, we're not having kids. Is that normal? Are we fertile? So you just have to sit down and then understand where they're coming from and meet them there, and then go through the process.
Yeah, I asked that question because you mentioned Taboo. And I think there's probably a lot of men listening that are thinking, I'm not sure whether I could feel comfortable asking these questions. So I'm kind of just interested, if you were a fly on the wall, the kinds of things, that that you would speak about with your patients, but I'm guessing that it's kind of everything.
It is everything, and this is the importance of these podcasts. Like, you just get more accessible information to these men and these individuals by telling them you're not alone. Like, once a patient feel that they belong to a community who are going through the same conditions and issues, it's easier for them. Once you give them a direction of access, where to go, who's the right person to talk to, you just facilitate the whole process of healthcare.
I recently had my sperm analyzed by a company called Legacy, and that's actually how I found you.
All right.
And how this podcast sort of came about, the origin story. And I was doing it for academic purposes. It came up previously in an episode that you could do a kind of sperm analysis.
Correct.
And my partner and I are certainly, talking about having kids in the next couple of years. We haven't sort of tried, but I thought for academic purposes, I'd like to do this semen analysis and just see, what the results kind of say. What can you tell us about semen analysis? Is it worthwhile? Who and why should a man kind of consider it?
Yeah, this is a great question, because semen analysis is, again, not a perfect test for fertility. It just tells us, physician, what's the likelihood of a patient conceiving naturally, right? So think about it as a snapshot in time that would give you the quality and the quantity of sperm. The main question we're trying to answer is, do you have enough sperm who would swim from the vagina to the cervix, to the uterus, to the tube, to meet the egg and fertilize an egg? And the only way to know is to test the sperm. The good news is, for men, it's super easy. It's just like, you go, you provide the sample, which is not the worst thing ever.
There's a few steps involved in how you collect that sample.
It's
Leave
not
it
the
to
worst
there.
experience ever, though, compared to female, where if you want to test the female fertility, it's a whole different process. It's probably a week of testing and imaging modalities and hormones and blood work. And it's way more painful for a female to test the fertility versus a man, which is a simple one-time test that you can do, and we can get a lot of information out of this test. So basically, a semen analysis would give me the volume of the sperm. How much sperm do you have in this ejaculate? It'll give you the concentration. How many sperm do you have per volume, per ml? We call it million per ml of sperm. And then it'll give me a quality of the sperm. What's the ability of the sperm to swim, which is the motility of the sperm? And how does the sperm look? Does it have one head, one tail, all the measurements are good? Or do they have sperm with two heads or two tails or a short neck? And this is the morphology.
What's optimal when it comes to...
So we have a reference range that's set by the WHO, the World Health Organization, and they have the 6th edition. They give us a reference range, meaning that they got around 4,000 men who are fertile. They did an average. And they said, if a patient is testing their sperm and they're above the 5th percentile of all of these men, they're considered normal. They're considered to have a normal fertility potential. So we have specific numbers. For concentration, it has to be more than 15 million per ml. For volume, more than 1.5 ml. For motility, more than 40% of the sperm that are swimming. So once we get this test, we don't look at one individual parameter.
No, because presumably that 40% is directly affected by the total count.
Correct. This is a great point. So once you get this sperm test, you should not focus on one parameter. This is why we devise something called the total motile sperm count. It's basically a compounded number on how many sperm do you have able to swim up to meet the egg and fertilize it. And it's a number you can calculate by multiplying volume times concentration times motility. So if you multiply like the 1.5 by, let's say, concentration of 15 million by 0.4, you'll get this TMC. We call it, it's a TMC number. And once this number is more than 20 million, then I look at this number and I tell the patient, you know what? At this point, you shouldn't have major problem conceiving naturally. If the number is lower, then we have to tell the patient, you know what? This number is a bit lower than the reference range. Maybe it's a better idea to dig deep and see if there is any correctable reason on why these numbers are lower than the reference range.
And you mentioned at the outset that we don't really understand how these numbers have changed over time, over decades?
We think they're going down. We don't know why exactly. So we know that 50 years ago, the concentration and the total motile sperm count were higher than that. The 50% figure is controversial. Like some scientists say this is not accurate, it cannot be 50%, because if the progression continues in 2050, no one will have sperm. Like that, if you decline another 50% in 50 years, some scientists say like every single couple are going to need IVF in 2050.
So that's like
doomsday.
That's a little alarmist.
It is. We think it's somewhere in the middle, but we admit that, and we acknowledge that there is a decline. And this decline is mostly driven by lifestyle and environmental factor. So what we're exposed to and what we do actually is clearly affecting sperm and germ cell production in our bodies.
If you're serious about optimizing your health, I've got something for you. 8 Sleep and their revolutionary Pod 4 Ultra. The Pod 4 Ultra is not just a mattress cover, it is an entire sleep system. With advanced temperature control and biometric tracking, the pod has helped me take my sleep and recovery to the next level. And as someone who is always looking to optimize health, better sleep means better everything. Focus, energy, workouts, and even better communication with my partner, Tawny. What makes the Pod 4 Ultra so incredible? Well, it learns your sleep patterns and adjusts the temperature automatically throughout the night, optimizing your body temperature during the 4 stages of sleep. If you're ready to take your sleep and recovery to the next level, head over to 8sleep.com/theproof and use the code THEPROOF to get $350 off your very own Pod 4 Ultra. The best part is that you still get 30 days to try it at home and return it if you don't like it, but I'm confident you'll keep it. Trust me, your body will thank you for this investment in better sleep. Shipping to many countries worldwide. See details at 8sleep.com/theproof. Is there a top 3, and we'll walk through that list, but if you were to say, these are the top 3 things for the dude listening, or perhaps the female partner listening who's going to pass on this information, top 3 things that would explain why these semen parameters are becoming sort of more and more suboptimal?
So I would say one of the top 3 is exposure to toxins, environmental pollution, and pesticides and plastics. So we know for a fact, like it's scientifically proven, that these molecules are absorbed into the cellular level, molecular level, and that they're affecting the function of the sperm and production of the sperm. So they're affecting the actual quality and quantity, but also the ability of the sperm to fertilize the egg. The problem is it's everywhere around us. Like everything we're touching, everything we're breathing.
Even condoms.
Everything, even condoms. But we don't want condoms for fertility, right? So this is good. But everything that we're exposed to, everything that we eat, has some sort of contaminant, whether it's bisphenol A, BPA, or BPS, or phthalate, or heavy metals. And these are clearly a factor in the decline and dysfunction of the sperm. So you should be very conscious and aware, especially in a period where you're trying to conceive. Like, if you're not trying to conceive, you know what, just live your life, be healthy. But if you're trying to conceive, you have to start thinking and guiding your life into a more healthy well-being. So you have to think about what you're eating, how you're exercising, how you're sleeping, your stress level. You have to be conscious about these factors because they do affect your fertility potential. They do affect semen parameter.
What if you had a patient in front of you who said, okay, well, we live in this world. What are the best ways for me to kind of reduce my exposure to those environmental toxins without just locking yourself up indoors?
My spiel in clinic is divided into three parts. The first part is anything that's healthy for you is healthy for your sperm. So think about if you eat well, like a good Mediterranean diet, a lot of fish, omega-3, green stuff, no added sugar, no processed foods, this is going to be good for sperm. Anything that increases the temperature around your scrotum is bad. So excessive hot tub, jacuzzis, saunas. If you put your laptop on your laps for extended period of time, this is going to have heat on the testicle. This is bad.
What about phone in the pocket?
It's controversial. So some studies are saying that these radiomagnetic waves have some side effect on sperm. We don't have a solid evidence saying that there is a correlation between cell phone use or putting your cell phone in your back pocket or your front pocket and semen abnormalities. We have some studies here and there saying there might be a correlation. Again, it's very important to understand that correlation is not causation, right? And then the third category is anything in excess is bad. So excessive alcohol consumption, smoking is extremely bad. Marijuana, recreational drug, is also bad. Marijuana is again controversial. We had some studies proving that it has no effect whatsoever on semen parameter and semen function. Newer studies are showing that marijuana itself has no side effect. However, the chemical composition of marijuana is very similar to estrogen. So when people are smoking weed or like doing edibles, there is a higher concentration of estrogen versus testosterone in your body, and this is going to lead to sperm dysfunction. It's not the actual marijuana. It's like just because the molecule looks like estrogen, and this is what's causing these problems.
So these things like cannabis or jacuzzi or sauna, what parameter are they? What semen parameter are they affecting? Is it
they're affecting
motility?
mostly the quality. So the morphology and the motility of the sperm.
So shape and what percentage
the
is swimming?
Correct.
Okay. And where does kind of sperm DNA damage come into this story? Is that distinct again?
It's a separate from the quality and the quantity of the sperm. So you have quality of the sperm, quantity of the sperm, and then the DNA integrity. Like how healthy is the DNA inside of the sperm? So the only function of the sperm is to deliver DNA into the egg, right? We don't have, again, great ways to check how healthy is DNA. Is it like the best DNA you can have with no mutation, like really clean, that's gonna swim and go into the egg? There's something called a DNA fragmentation test, which is, again, an indirect test to give us an idea on how much stress is the sperm undergoing. We call it like oxidative stress. Is the sperm under a lot of pressure and tension, and you can feel that the DNA itself is not stable, and you have a lot of breakup and mutation in there. This is shown by the DNA fragmentation test.
Mm-hmm. Yeah, I didn't do that test. I don't think it was part of the sperm test that I did.
It is. So Legacy is the only at-home mailing kit that would offer this, because usually it's a very complicated test to perform. But they were able to do it through the same kit. If you have normal semen parameters, it's unlikely for you to have bad DNA. They go hand in hand. Like if you have good sperm, good quality, good quantity, there is no reason why the DNA should be affected, right? Usually they just follow, the trend follows each other.
Jacuzzi and sauna. What's the mechanism here? Are they just literally heating the sperm up so much they're kind of cooking it,
frying the sperm,
and it just dies?
It doesn't die. It's gonna be affected. So think about why the testicle sits in the sac, because they need a cooler temperature compared to the internal body temperature. So it's 2 degrees less than the internal body temperature. So when you expose these testicles sitting in the sac to high heat, you're going to increase the temperature back, right? This is like you're defying nature.
I think I've seen on a Reddit a Reddit forum, and I certainly wouldn't recommend people get medical advice on Reddit, but I saw a few people talking about they didn't want to give up their sauna, and they decided to go into the sauna with an ice pack.
I mean, and this is, again, you should, or what I do is I do respect the wishes of patients. Like when they come to my office, I'm not trying to torture them. Like if someone comes here and say, you know what, sauna is my number one priority, it's part of my well-being and my ritual, I don't want to give it up. We can work something whereby I say, how about you do it less often? How about you stop it for a couple of weeks before you're trying to conceive? Because the sperm cycle is 74 days. So every 3 months, you have a new batch of sperm being produced and ejaculated. So the test that you did was a reflection of what happened 3 months ago. So if you're trying and planning to conceive, let's say in 6 months, maybe just the 3 months or so before this date, you can try to modify how many times you're going to the sauna, how much you're spending in there. It's all about moderation. Like if you go there maybe 2 times a week for 10 minutes, this is not going to be bad. If you go there and sit for an hour every day, you're going to have your sperm factor.
And is this something that you think all men who are sort of planning to have children should be thinking about, or is this more reserved for the bucket of people who are having difficulty conceiving?
So you can think about it in 2 ways. If you're a man trying to conceive and you did a baseline semen analysis and you don't have any abnormalities, your numbers are in the millions, then you have a bit more of a room, of a leeway, right? There is a buffer there. So you have like some leeway to go and do some bad stuff for your sperm. If you're a man trying to conceive, but they don't want to do a semen parameter, they have to optimize every single factor they can control, including the exposure to heat, including the smoking, including a good sleep, less stress, exercising a couple of times per week. All of these factors, again, are good for your health. And because they're good for your health, they're going to be good for sperm production.
Right. And back to the life cycle being 74 days.
Correct.
If you make these lifestyle changes today, it's going to take 74 days until those changes have had full effect on the quality and amount of sperm 100%. That you have.
And this is the same for any medication that we give these patients, or any surgery, or if they're taking testosterone replacement therapy. You have to, and we'll talk about this hopefully later, anything that you change today, it needs at least 1 to 2 sperm cycle for you to see the effects.
So you might even allow 148 days.
Correct. So up to 6 months.
Mm-hmm.
Yeah.
Got you. The test that I did with Legacy, so that was a sample that I did at home. I sent it off to the lab. And by the way, Legacy are not paying me or sponsoring the show or anything. Is that test different to if I walk into CVS or Walgreens or places like this that sell sperm testing kits that you can just buy off the shelf? Are they equivalent?
Yeah, that's a great question. So I'm the chief medical officer of Legacy. I oversee their scientific program, all the research, any development of new products. So there's a big conflict of interest, right? But I'm just going to be as honest as possible. The physical lab where you go into a hospital or clinic and you do the semen analysis test is still the gold standard. So companies like Legacy are not trying to replace the gold standard. Like if you go to a traditional urologist and you want to test your semen or your fertility potential, they will send you to an andrology lab, a physical lab, whereby there is no adding a medium or there is no transport, right? Legacy filled a big gap in the practice whereby men were just very, very afraid and reluctant to go to these places because it's probably one of the worst experiences you can go through. Like going to an andrology lab, first of all, the collection room is either a very dirty small room with outdated porn DVD, like this is where they are, or some people don't have resources and they send you to the restroom,
or shame,
or like you're trying to produce your sample and you can hear people passing by in the corridor. So it's a very, very unpleasant experience, and this was a major barrier for men checking their fertility potential and doing their semen analysis. So Legacy came in and said, you know what, we're going to fill this gap by getting these kits to your house, so you can produce a sample from the comfort of your house. Like you can do wherever you want to do, have around you whoever you want to have to produce a good sample, and then ship it overnight. And then we're guaranteeing very similar quality and quantity of the results. It's not going to be 100% exact number as doing it in a lab, but it's going to be very, very close, whereby this difference is not going to be clinically significant. And once you do that, this is your first step towards testing. Like if you do this test and then you have some problem, then you come back to me and you tell me, hey doc, I tested this semen parameter with you guys and there is some abnormal numbers. And my next step would be, then you have to go to a urologist and maybe you want to retest in a regular andrology lab to make sure that these numbers are accurate and take it from there. So again, it's still not the gold standard of semen testing, but it's the next best thing that you can do or you have, which is affordable. It's way cheaper than doing it at an andrology lab. It's covered by insurance, and it's from the comfort of your house. Like, you have all the privacy you need. So it's making the process way better and more accessible to men and couples.
And how is that different to what you could walk into CVS and buy?
So those CVS tests, like Yo or other tests, they don't give you a detailed clinic grade test. They're just checking if you have sperm or you don't have sperm. So it's just like sperm check or low sperm X. The legacy one is an exact replica of a test that you get from a lab. Like, you have the volume, the concentration, the motility, the morphology, the DNA frag. So it's like doing it at the lab. The other test is just a triage. Like, you go there, do I have sperm? That's it. This is probably the only information you know.
How modifiable are these parameters? So I think you said, if I listened correctly before, volume by concentration by motility.
Correct.
You want that to be over 20 mil.
Correct.
So let's say someone comes into you and they're at 10 mil. If they were to go and make lifestyle changes, how much could they potentially improve that number? What have you seen in clinic?
Yeah, this is a great question. So if a patient comes into my clinic and they have a lower total motile sperm count, I need to know, why is this the case, right? Is it a problem only with their lifestyle, which is usually it's unlikely for someone to have a drop in 10 million just because of their lifestyle. Most importantly, is there any medical reason that I can help them correct to improve these numbers back to normal reference range? Or is it a combination of both? And usually it is a combination of both. Usually people and patients are unaware of factors that might decrease the quality of their sperm. So we go over, again, this spiel of live healthy, sleep well, exercise, maintain a good BMI and weight, don't expose your testicle to heat, smoking, excessive alcohol, recreational drug is bad. So go over these lifestyle changes. And we work together on how to improve and incorporate this in their everyday life. Like, again, you don't want to torture a patient. You don't want to force them to do things that won't work for them. You want them to be compliant. And the best way for them to be compliant is to work with them to understand their lifestyle and day-to-day life. But then you have all of this algorithm that we have to go through. So the American Urological Association, the American Society of Reproductive Medicine have specific guidelines on what we should do if a patient comes back with bad numbers. There's no bad or good, like numbers that are lower than the reference range. So we start by doing a physical exam. So we have to check for a condition called varicocele. So varicocele is basically a dilation of the veins around the testicle. When these veins are dilated, they're gonna bring more blood into the testicle. You're gonna have a higher temperature and some stress for the production of the sperm. So this is the most common correctable cause of male fertility. So once we do this physical exam and I tell the patient, oh, you have this varicocele, then we go into that, what should we do now, or how to fix this varicocele. So this is from a physical exam perspective. From a lab perspective, we have to order some tests to make sure that there are no hormonal imbalances leading to sperm dysfunction. So you have to test for FSH, LH, testosterone, sex hormone binding globulin, prolactin, and albumin, which are basically the main reproductive hormone. These are the key element that are going to go to the testicle and tell the testicle, hey, have a healthy production of sperm.
Maybe it's worth double clicking on that.
All right.
So just like a basic overview of the HPG axis and how the body is producing sperm.
So there is a feedback loop. We call it a feedback loop. There is always a communication between the testicle, which are the factory of sperm production, and the brain, which is, think about it as like the command. So the brain, and specifically in the brain, there is a pituitary gland that would send signals to the testicle to tell them, hey, produce sperm and produce testosterone. And these are the FSH and LH. So the LH will go to a specific cell in the testicle called Leydig cell to produce testosterone. And the FSH will go to the Sertoli cell to tell them produce sperm. but then also the testosterone is important for sperm. So everything is linked together. And then you have a feedback loop from the testicle themselves. If the testicles are not producing enough sperm, they go back to your brain and tell them, hey, I want more FSH, LH because we want to produce more. So everything is related in very, very, very tight control. This is like a small overview. It's a bit scientific and nerdy, but this is how it works.
No, it's interesting. So by looking at sperm parameters, but then also at some of these hormones, you can start to, if there is an issue, you can start to kind of drill down on,
Correct.
Is that happening at the level of the brain hypothalamus, or 100%. Is it in the testes?
Is it like a hormonal problem? Is it a factory problem? And then it's like putting a puzzle together. Like you need to put all the pieces to understand why you have this outcome. So you do the physical exam. Sometimes we order a scrotal ultrasound. Just if you're suspecting any cysts or masses in the testicle, you do a scrotal ultrasound. You do the blood work. But then, again, these guidelines would tell us if a patient has very low number of sperm, you have to make sure that they don't have any genetic abnormalities. So we do a karyotype test. We count the chromosome.
What's very, very low?
Less than 1 million sperm per ml.
Total count?
Correct.
Okay.
Correct. Or azoospermia. Azoospermia is by a condition whereby the patient will provide a sample and the technician would be looking and there won't be any sperm. This is called azoospermia. It's 1% of the total population. Like every 100 men, 1 man has no sperm in the ejaculate.
What do you see when a man comes in who has been taking exogenous testosterone? Let's just say, for example, a dude in their 20s, and this is rife today. There's, with social media, kids in their 20s are just blowing up bigger and bigger, in the bodybuilding scene. And so there's so much use of exogenous testosterone. You mentioned there's a relationship between testosterone and sperm health. What happens to that feedback loop and to sperm if you are injecting testosterone?
This is the pain of my existence for the last year. It's not the actual testosterone. I have a lot of patients on the actual testosterone. It's the lack of education by the provider or the online clinic on the effect of exogenous or external testosterone on sperm production and fertility. Because again, unfortunately, the trend is sell more testosterone. People are feeling great. It's like it's like if you need it, it's a great way to feel back normal, or like to have raised laser focus, or like you feel energetic and you can conquer the world, right? But then there is some side effect of taking testosterone, and people and patients should know about these side effects because they need to make an informed decision on if they want to take it, when they want to take it, do they need to do any steps before taking it. And this is the main problem that I'm seeing every single day in my clinic. Patient would come to me, they would say, hey doc, we're trying to conceive, we did the semen analysis, we have no sperm, we've been on testosterone for the last 5 years, no one told us this is going to affect fertility. So the pathophysiology of it is, if you take testosterone, we call it exogenous testosterone or external testosterone, your body's going to perceive it as, whoa, I have a lot of circulating testosterone in my blood. Why would I spend energy and produce my own natural testosterone from the testicle?
So that's happening at the level of the hypothalamus?
Of the testicle. So the testicle would feel, and the brain would feel like, I have plenty of testosterone. I should not produce my own natural testicular testosterone. So this will shut down. With the shutting down of testosterone production, you're going to also shut down the sperm production. But also the natural testosterone is the only fuel for sperm production. So if you take, no matter how much you take testosterone, this is going to be negatively affecting the sperm.
Exogenous testosterone doesn't act as fuel for sperm production.
No, it acts the opposite.
Interesting.
It doesn't affect whatsoever, it makes it worse. So most men on exogenous testosterone, again, they're going to drop their natural testosterone and they're going to drop their sperm to 0. Like if you take it for an extended period of time, 5 years, 7 years, the likelihood that if you do a semen analysis, these numbers are going to be extremely low or zero.
So there's not a feedback loop from the testes saying, hey, there's no sperm here, produce sperm.
No.
The body's just detecting testosterone.
Correct.
You're ramping it up with exogenous.
100%.
So the brain basically says, we don't need to send that signal.
We don't need to send the
testes.
signal to produce sperm.
So there's no sperm production, there's no natural testosterone
Correct.
production, and then essentially the testicles just shut down.
Exactly. So this is why, again, most couple on TRT, they're going to have a shrinkage in their testicle. Like the testicle are not functioning anymore. They're not producing sperm. They're not producing testosterone. So the volume of the testicle in most patients on TRT are going to shrink to almost nothing.
What does that look like? Like, what's the normal size of a testicle versus a
around
shrunken testicle?
4.5 centimeter in longitudinal axis.
That's normal.
That's normal. And then you're going to have a major shrinkage of the testicle. The problem is around 15 to 20% of men, these changes are irreversible. And this is the problem. Like 85% or 80% of men, if you stop testosterone, you might reverse this process and the testicle would wake up, they start producing their natural testosterone and sperm, maybe not to their baseline, but you're going to have at least something to work with.
Enough to conceive.
Correct.
But presumably that has a lot to do with how long they've been doing it?
Correct. It's the dosage and the duration of treatment. So these 15 to 20% of men have irreversible damage and they cannot conceive naturally because the testicle has been shut down for an extended period of time and it's not waking up. We have ways to deal with it, but it's a long and painful process. Like you have to give them a lot of medication like ACG and clomiphene citrate to try to tell the testicle, wake up, now we need you to work again. Sometimes you're successful, sometimes you're not successful. So this is why having a very honest conversation with whoever is prescribing testosterone is very, very important. The first question for a patient in my clinic is, do you want to conceive in the future? If the answer is yes, then I have to sit and explain the exact same thing that we just said and give them the option to either delay their TRT or to freeze some sperm before starting TRT, which is one of the best idea, right? So I tell them there is almost 100% chance that these semen parameters are going to get affected. They're going to go to very, very low numbers. Freeze the sample before you go on TRT. This way you have an insurance policy. Whatever happens, you have something to use in the future. This something cannot be used for natural conception. It's going to be used for IVF or IUI, but at least you have something, right? Or we give the patient the option to take something like clomid or ACG with the TRT, with the testosterone, to keep the sperm production going.
So those compounds essentially just mimic the signals that come from the brain to the testes.
FSH and that H that would go to the testicle to tell them, stay awake, don't go to sleep.
Okay, and is there any issues with doing that?
We don't have long-term data on taking ACG for like 5 years or 10 years, number one. Number two, it's a very expensive medication. There's a big shortage on ACG. They usually come from a compounding pharmacy. It's very complicated to do that. So freezing sperm, if a patient would go on TRT, is the best option. Second best option is take TRT and then take with it, along with it, some medication that would help keep the testicle alive. Third option is try to conceive before you go on TRT. Like if you don't want to freeze and you want to go through IVF or IUI, then try to conceive a baby and then start your TRT after that.
Yeah. What would you say to the dude in his 20s that's listening and is either taking testosterone or thinking about it and just thinks, I'll deal with this when I'm in my 30s or 40s?
I just want to say that they're not alone. Most patients on TRT don't know the side effects on fertility. This side effect is almost always happening. There's no way a patient or individual taking TRT, they're going to have some side effect on the fertility potential. It's up to them to educate themselves and take some actions. And company like Legacy are again providing a better alternative than them freezing sperm in clinics or labs, because one is way cheaper than freezing it in a regular lab. Two, it's more accessible. They can get the kit, provide the sample, freeze it, and then do whatever they want. And they just need to have to make an informed decision about their TRT. Like they need to ask about the side effect of TRT, whether fertility related or not fertility related, because testosterone also affects the blood viscosity. It might predispose patient to having strokes or deep vein thrombosis. Very, very minimal side effect, but they're there. So they need to stay away from organization or physician who are just trying to make more money out of them, because it's a big growing business of giving TRT. It's very easy for the practitioner or the clinic to just prescribe TRT. They have to do it in a scientific way with someone who's following them up, talking to them about the side effect, and then doing every 4 to 6 month labs to make sure that they're safe. Make sure that their prostate specific antigen is not going up, to make sure that the levels are not shooting above 800 or 1000, and to make sure that the viscosity of their blood is still within normal. So my patients, I have to see them every 4 to 6 months in my office, as long as they're taking TRT. If they don't show up, I won't renew their prescriptions.
Right. Yeah, I think there's a lot of people that are just winging it.
Right.
Flying blind,
I know.
thinking that my body's 20, I'm resilient, yeah. This will be reversible. I'm not doing any long-term damage.
It is reversible, not in every case. Mm-hmm. So around, again, 20% of men, we can't get sperm back.
Right. I actually froze my sperm.
Yeah, I'm proud of you.
Not only just as an insurance policy, like you said, in case something happens. So I think I have 4 vials.
Good. Yeah.
Frozen.
I mean, life is so unpredictable.
Yeah.
And then when you freeze your sperm at a younger age, the quality of the sperm is better. Like we had this big misconception of there's only an advanced age for female. Like we call them advanced maternal age. But now we have a lot of studies and body of evidence showing that there's also something called an advanced paternal age, whereby there is a decline in the quality and the quantity of the sperm every year after the age of 40. So 40 is the cutoff for men, 35 is for the female. So after the age of 40, we start telling patients that there is something called the advanced paternal age, whereby the quality and the quantity is going to decline. But also studies are showing that the older you are as a dad, the higher the risk of having offsprings that are affected with autism or schizophrenia or depression or some genetic abnormalities. The risk is not substantially higher, but it is higher than the general population. I'm trying to scare you by saying that older dad will have offspring with problem. I'm just saying that the risk, if you compare it to the general population for autism, schizophrenia, bipolar disorders, and some genetic abnormalities, is a bit higher if the older you get. So the younger you freeze the sperm, if you want to use it for future conception, the better. Like you have a sperm in your 30s, is going to be a better quality, healthier than a sample in your 50s or late 40s.
And perhaps if you're thinking about getting a vasectomy, but you're unsure whether you want kids in the future.
100%. This is why every single patient of mine, before their vasectomies, I sit with them. It's like, dude, make sure you freeze a sample because you never know how things are changing. So the problem is when a patient is coming to do their vasectomies, in their mind, they're 100% sure. Like they're not going to have kids, not now, not in the future. But things change. Like people would have divorce, people would have something bad happen to their kids, or they change their mind, or they want kids. Reversing it is a big ordeal. It's not covered by insurance. Reversing a vasectomy is super expensive. Sometimes it's not successful.
Do you know what percentage reversing a vasectomy is successable?
So around 80% of the time we reverse it and it's successful. It's pretty high. But the problem is success has different definition. If you're defining success as having sperm in the ejaculate, it's something. But sometimes you don't have enough sperm to fertilize the egg. So you still have to use IVF, right? So you're able to put the two back together and to get sperm, but the sperm would not be enough to fertilize naturally. right? So it's very complicated, the whole reversal process. Having a sperm sample frozen is way easier. The catch is you have to use the sample either for IVF, which is in vitro fertilization, or IUI, which is intrauterine insemination.
This episode is proudly brought to you by NordVPN, my go-to VPN for secure internet browsing at home or on the go. A VPN, or virtual private network, creates a private, secure connection by routing your internet traffic through a middleman server, protecting your data from hackers. This is especially important on public Wi-Fi, places like airports or hotels, cafes, places that I tend to be quite regularly, where our information is most vulnerable. Beyond protecting you from risks like identity and credit card fraud, NordVPN is also great for accessing geo-restricted content. I'm not sure whether I should be sharing this, so let's keep it between friends here. Using NordVPN, I can connect to a US server while in Australia to stream movies or sports unavailable locally. Yeah, I do that. NordVPN truly simplifies online security and opens a world of content, all for the price of a cup of coffee per month. I use it across all of my devices, including my phone. Stay protected and enjoy more freedom online with NordVPN. To get the very best discount off your NordVPN plan, go to nordvpn.com/theproof. Our link will also give you 4 extra months on the 2-year plan. There's no risk with Nord's 30-day money-back guarantee. You can find this link in the episode description. If you haven't done a sperm analysis with a lab, can you eyeball sperm health? So if you look at it and you see color or viscosity or volume, are there properties that would indicate healthy semen versus unhealthy? Or if you jump on TRT and you're not taking those compounds, like what would happen to volume, color, viscosity?
So this is a great misconception in men. Like when they ejaculate and they perceive that it's like a normal volume, a normal color, they think that the content of the sperm and the ejaculate is normal. Actually, the sperm is the smallest cell of the human body. The egg is the biggest cell. It says the iron. Like the egg is actually the biggest cell, and the sperm is the smallest cell. There's no way someone can see what's going on in the ejaculate. So people think I'm ejaculating. Like the color is good, the volume is good. I'm pretty sure there is sperm in there, and this is not the case. Even patient with azoospermia, with 0 sperm, they have normal volume, normal color, normal pH.
That's deceiving.
It is. Patient with after the vasectomies, they have normal volume, normal ejaculate. So there's no clear correlation between the physical appearance of sperm, of ejaculate, and the actual sperm concentration or quality of the sperm.
So when do you think someone should test their semen? Like clearly, I said I did it for academic purposes. It's not that I'd been trying or had any difficulties. Is it something that someone does after they've been trying to conceive and they're having some issues there and they're trying to diagnose whether it's male, female, both of them? Or do you think people should just proactively be doing it?
It depends who you ask. Like if you follow the guidelines, the American Urological Guidelines and the American Society of Reproductive Medicine, the ASRM, they have clear condition on when you need to test for sperm production. It's basically if you're a couple or an individual trying to conceive for X amount of time and it's not happening, then this is an indication for test. 12 months, but now they removed this 12 month. It's like just if you're trying to conceive and you're not able to. But then if you look at society in general, people are more aware of fertility. They want to know the fertility potential. And company like Legacy are giving them access to do that. So I think every man should just test their sperm at some point, even if they're not trying to conceive or they're trying to conceive, because having a baseline is the best evidence of what to do next. It's basically, should we go and pursue a urology and do all of these tests and figure out if there's a problem, or should we do a semen analysis and freeze it to have an insurance policy, or should we do a semen analysis and just make sure that we're fertile, right? So this is the second category. The first category is people trying to conceive, unable to conceive. there's a medical need to do the semen analysis. People interested in fertility potential, they want to know, or they want to act and be proactive. And you have the third category, transgender population, gay couple, they're gonna, let's say, go on hormone replacement therapy or like trying to do surrogacy, and they want to know, so they have to test. And then the fourth category are people going on TRT, testosterone replacement therapy, they have to test and freeze. So basically everyone, like if it's medical and cultural and society, everyone, because of the easiness of the test. It's not a test that you need a medical prescription or extremely expensive or it has some side effect or adverse event of doing it. It's just something that's very easy. You can do it from the comfort of your house. It's accessible, it's cheap. So doing it is always a good idea.
And we kind of touched on this, but what kind of changes to sperm parameters could someone expect just from lifestyle alone? Let's just say we put the medications to the side. What have you perhaps seen clinically?
I would say around 15 to 20%. So if you eat healthy, you get all of these antioxidants and nutrients and vitamins, you're giving the fuel to the sperm to be produced in a healthy way. So we have all of these vitamins, vitamin A, vitamin D, vitamin C, antioxidants, like coenzyme Q10, which is the one with the most robust scientific publication. So it has been shown that taking CoQ10 300 milligram per day has been shown to have a lot of positive effect on sperm. You'd ask me, like, can you quantify this positive effect? Usually it's around 15 to 20% improvement in the parameters.
And that's with like a whole range of lifestyle changes.
Correct. So lifestyle changes, multivitamins, antioxidants, and then these molecules like folic acid that would support cell division and molecular health are also very important. So it's like taking a multivitamins that people would take, but specifically for the sperm. So Legacy has a good multivitamins that has CoQ10 in it. You have a lot of multivitamins on the market. Just people can choose whatever. They have to make sure, though, that it has this CoQ10 in it, or they have to supplement it with the CoQ10.
Yeah. What about minerals like zinc and selenium? They often come up.
Again, zinc, selenium, ashwagandha roots, all of these are good for sperm. The problem is we don't have clear evidence on the causation. Like I cannot tell you if you're going to take zinc, selenium, all the vitamins, the CoQ10, your sperm is going to improve. We just have soft evidence that taking these are going to support sperm production, are going to decrease the oxidative stress that happens around the sperm, and the outcome would be or should be a better parameter.
Mm-hmm. I saw an interesting trial on walnuts.
Yeah.
I don't know if you saw that.
I did.
That I think they fed, if I remember correctly, it's like a handful of walnuts. It was healthy men.
Correct.
So this wasn't men that had infertility.
Correct.
And the group that, I think it was just like a Western diet, one group added walnuts, and over the period of that trial, a couple of months or something, 3 months, they saw some improvement in semen parameters. What do you make of that?
We just like these studies because if we have a lot of patients asking these, they want to do actionable intervention, right? Like they want to say, if I eat nuts or walnuts every day, would I have a better semen parameters? And my answer is eating nuts is a general healthy. It has a lot of omega-3, and probably this omega-3 is going to support sperm production. So it's not a bad idea. Again, moderation is key. You should not eat like pounds and pounds of nuts. It has a lot of calories. So just being healthy, eating in moderation, all of these good food, like a good Mediterranean food, supplementing with vitamins, antioxidants, selenium, zinc, ashwagandha roots, CoQ10, most importantly, will help support sperm production.
When you say supplementing with antioxidants, like vitamin A or
Correct. So,
lycopene, or what are we talking about?
So all the vitamins, the CoQ10, selenium, zinc, and folic acid, and ashwagandha roots.
Okay.
And usually you can get all of these in one pill.
You're right.
You can just take it.
Is there any evidence that the type of fat that people eat, like saturated versus unsaturated fat, affects any of these semen parameters?
Yeah. So trans fat, saturated fat, processed food are all bad for sperm. So you should eat the healthy fat, like the all the omega-3 and all these type
Right, so
of
olive
good
oil,
fat,
fatty fish if you eat
avocado,
fish.
fat fish, walnut. All of these have the good fat. And it's not only healthy for sperm production, it's going to be healthy for your heart health and your mental health and your brain and your gut, but it's also going to affect positively sperm production. So think about sperm production and testicle as part of a system. So whatever is good for the system is going to reflect positively on sperm production. So there is no one single food as a superfood that's going to go and target sperm to make it better.
What about some of these more controversial foods? Before you mentioned a compound mimicking estrogen, and this is where like foods like flax seeds and soy will come up a lot. And you can find all sorts of information online. How do you feel about these foods that are rich in isoflavones or phytoestrogens in terms of whether or not they affect sperm negatively, neutral, positive?
Right. So going back to the physiology of sperm production, you need testosterone. This is the fuel for sperm production. In the human body, there is a tight ratio between estrogen and testosterone. When one goes up, the other goes down. So intaking a lot of estrogen or estrogen mimicking molecules is going to disrupt this ratio. So you're going to have more estrogen, and naturally the testosterone is going to go down, and this is going to negatively affect sperm production. However, again, moderation is key. If you eat soy once or twice a week and your diet is not soy based, like every day you're eating it breakfast, lunch, and dinner, it shouldn't affect you. If you're just eating it in a healthy way, just as an alternative for protein or getting some more minerals and vitamins, this is going to be actually healthy.
Right. Yeah, I hadn't really come across. I think I tried to look up if there was any studies looking at soy and semen directly. I'm not sure if you'd seen that. I didn't see much, but I did find some research looking at soy and at least testosterone and estrogen.
Correct.
And this was like a meta-analysis of studies spanning, I think, anywhere from like 2 weeks up to 52 weeks.
Correct.
And within that study, when they were comparing like around 3 serves of soy, that was actually per day, of a variety of different soy foods. So some of them don't contain a lot of isoflavones like soy milk. They didn't notice any significant effects on testosterone.
Correct.
Yeah.
Again, it's just how much you're intaking and for how long. It's just like if you're overdoing it with everything, if you overdo animal protein or fish, or you just on a strict vegetarian diet and you're not supplementing with all the minerals and vitamins, this is not going to be healthy for your sperm. If you over exercise, if you run marathons and you get very skinny and you're in a state of caloric deficit for extended period of time, this is going to be extreme for the testicle and sperm production. So anything in moderation, whether soy, foods, exposure to heat, alcohol consumption, is going to be okay for the sperm. It's going to be healthy for the sperm, right? There are some factors like smoking. We know that any smoking is bad for sperm. It's like if people smoke nicotine and cigarettes, this has detrimental effect on sperm, and this is proven. Like there is no gray area about it. Like if you smoke, you're going to have lower semen parameters, abnormal genetic and epigenetics content of the sperm itself.
Is that the same, do you think, with vaping?
We don't know. So vaping has been there for the last 5 to 10 years. We don't have enough longitudinal studies showing that. It's not the same with caffeine, though. So again, moderate amount of caffeine, around 4 to 5 cups a day, should be okay. Social drinking should be okay. If you go into like excessive caffeine intake, you're drinking like 10 cups a day, or you're binging on alcohol, this is going to be bad for sperm. Mm-hmm.
Back to like vegetarian style diets, how do you feel, or is there any evidence looking at how a vegetarian diet affects these sperm parameters? If
you're getting enough protein and you're getting all the minerals that you need to get through a regular diet, it shouldn't be affected. So if you're just on a very strict vegetarian diet without taking into account all the additional supplement that you need to take,
And then you're not getting enough zinc or
Exactly. You're not
selenium
getting
or
zinc
B12.
or selenium or folic acid, and
Right.
you're not getting enough protein and omega-3, then this is going to be bad for sperm. But if you're doing it in a more scientific way, it shouldn't affect sperm.
Right. So it kind of just comes back to being thoughtful
Correct.
about your diet. If you're going down a path of greater restriction, you need to be slightly more intentional, at least
You
at
have
the
to be
beginning,
mindful
to plan
of what you're doing.
Right. And you can get onto autopilot, but at the beginning, there's a learning curve
Exactly.
required.
Exactly.
So earlier you mentioned this relationship between testosterone and sperm production. We spoke about male fertility rates and that these may be declining, but some of that could be attributed to kind of diagnosis and better screening. What's happening to male testosterone levels? Is that changing?
So this is following the trend of sperm. So we think, and scientists have been proving, that the level of testosterone are declining in male for a multitude of factors. We don't know why exactly. We think that it has something to do with lifestyle, exposure to toxins like phthalate, we talked about, bisphenol A, microplastics. So a lot of studies have detected microplastics in the penis itself, in the sperm, in the brain, in the heart. So you have actual microplastic particles going into the cellular level of these sperm and sitting there and affecting somehow the function of the production of the sperm. So we know that. And then the problem with obesity, like we have an epidemic of obesity. Now things are changing with these newer medication like Ozempic and Mounjaro. But for the last 10 to 20 years, people are having unhealthy weight and higher BMI. And this is directly affecting testosterone production in two ways. One of them, people with higher BMI have more fat cells in their body. In these fat cells, there is this enzyme called aromatase that's going to transform testosterone and store it as estrogen. So the more fat cells you have, again, this ratio is going to go more towards estrogen, lower towards testosterone. And plus, people with higher BMI, the production of testosterone in the testicle is going to be inefficient compared to someone with a healthier BMI.
So if you're overweight or obese and you make lifestyle changes or use medications that help you move towards a normal BMI, you'll often see an improvement in sperm
100%
parameters?
improvement. So whenever you improve your natural testosterone level, you're going to see an improvement in the semen parameters. So the only way, so a lot of patients, this is a very common question in the practice, is how can we improve natural testosterone? You're telling us taking exogenous, external testosterone is not going to be good for you. How can we improve our natural testosterone? There's basically one way, is to reduce the fat content in your body and increase the muscle mass.
So resistance training.
So resistance training, training in general, cardio are just going to improve the parameter of the body composition. It's going to decrease the fat content in your body, improve the muscle mass, and the production of testosterone is going to go high. Sperm is going to
right, along with eating less calories, but presumably trying to still consume a healthy amount of protein.
Calories, correct.
Right. Okay.
Which is not easy. I'm not saying that this is like an easy way to do it. Like we all struggle with living a healthy lifestyle, and we're very busy. We're working. We have like families, and so like telling a patient, hey, you have to lose weight to improve your natural testosterone. I know it's not straightforward.
Particularly if you have dysregulated appetite.
Correct.
You're fighting this biological response, which
Correct.
is, excessive hunger in
Exactly.
response to your weight loss. How do you see GLP-1 agonists kind of tying into the story? Are they something that you're already using clinically and you're seeing some benefit with regards to male fertility?
So at this point, we don't have big studies showing the effect of these medication on fertility itself. We know that they're controlling the BMI. By doing that, they're going to improve the testosterone level and indirectly improve semen parameters. However, we have a lot of medication that would affect sperm production by themselves. Like blood pressure medication, antidepressant, all of these
As
factors.
in negatively affect
As in
sperm?
negatively affect. So we hope that these GLP-1s, like Ozempic and Mounjaro, would not have a collateral damage on the sperm itself.
Some sort of off-target effect.
Correct. We don't think so, but we have to wait for a couple of years to have enough people doing these longitudinal studies to see the pre and post semen parameters after these medications.
Okay. So promising, but we need a little more information there. Promising in that they're helping people lose excessive body fat. And presumably if you're coupling that with some resistance training, some cardio,
some healthy lifestyle,
high protein diet,
eating,
then you're improving body composition.
Correct.
You should be improving natural testosterone
This is
production. Interesting. That's also interesting about other medications affecting sperm health. So if someone comes in and presents to you, I'm presuming one of the things you're doing is looking at polypharmacy and all the medications they're on. What are the kind of most commonly prescribed medications to, say, men in a country like America or even Australia that they may not be aware of that are kind of negatively affecting sperm?
So this is a great question, because this is talking about the medical reason of why we might have a lower semen parameter. So think about the testicle as a factory. So you have something before the factory, the raw material or supply chain. You have the factory itself, and you have the after the factory. You want to get the product from the warehouse to retail. Exact same thing with the testicle. So we have pre-testicular reason on why the semen parameter might be low. We have a testicular reason. The factory itself is not working. And we have post-testicular reason on why the sperm is not delivered.
Which is like erectile dysfunction or
so
something.
The pre-testicular are all the reason that happening before the testicle. The testicle is working. It's healthy. Like if you give it a signal, it's going to produce sperm. So the pre-testicular are all the hormonal imbalance. There's problem with the pituitary, the brain, medication, anything that has to do with getting the good signal and the nutrients to the testicle itself. And drugs are included in this category. So this is the pre-testicular reason for male fertility. You have the testicular reasons, which are physiological condition affecting the actual production of sperm. They can be genetic, they can be a problem with the testicle itself, with the shape, with the anatomy. So something that's actually affecting the factory. And you're giving it the signal that it needs to, but you're not getting the outcome. Or you have the post-testicular, whereby you have good signals, good hormone, the factor is working, but then there is a problem in the transport. And then we usually call it an obstructive etiology of male fertility. So we have sperm. So if you go to the testicle, you have millions of sperm, but these sperm are not be able to be transported to the penis or to be ejaculated, either because of ejaculatory dysfunction or erectile dysfunction. Like you have sperm, but you cannot just have sex or ejaculate. Or a physical and mechanical obstruction in the tubes. So you have either a scar tissue or an absence of a vas deferens, whereby the sperm is not able to exit the body.
Mm-hmm. So pre-testicular, testicles being the factory,
and post-testicular.
And post being the transport or retail, getting to retail. Exactly. I love that explanation, by the way. Yeah. I'm sure you use that in clinic.
So going back to your question, so a lot of medication, part of the pre-testicular reason of male fertility, would affect it, like antidepressant, anxiolytic, antihypertensive, of course, chemotherapy, immunotherapy, all of these factors would affect sperm production. However, when I have a patient in my clinic, we have to have an honest discussion. I would never ask a patient to stop their antidepressant to get better sperm. Like it's just a matter of priority. Like I would just explain to my patient that this medication might be affecting sperm, but this is good for your mental health. Do not stop it. Let's have a conversation with your psychiatrist or counselor to see if there are any alternatives that have less of a side effect. So there's a provider should just think about the patient as a whole. I'm not just thinking about fertility. Like I'm not trying to help them have kids, but making them miserable or like doing some bad stuff. Like the motto of medicine is do no harm. So by fixing sperm, I should not mess their mental health, or I should not mess the blood pressure, give them a stroke with good sperm. So we try to do both, which is hard. Like it's hard to get everything perfect and optimized.
Right, you're trying to optimize the entire
exactly.
body.
You have to optimize the entire body. You have to think about the human body as a holistic system.
So those medications, essentially a medication could affect fertility at any of those three different levels.
Correct.
So another common one, for example, that you can read a lot about online, that men report issues with erectile function is like finasteride.
Correct.
Do you see that in clinic?
I see it a lot. So I'm not a big fan of finasteride. Finasteride is a medication that has specific use, mostly for an older population, whereby the main function of finasteride is to shrink the volume of the prostate. So people after the age of 50, they have this condition called BPH, whereby the prostate is starting to block the flow of the urine. One of the medication we have is finasteride. The problem with finasteride is it has the side effect called post-finasteride syndrome, which is a nightmare for physician and patient. It's basically an irreversible condition of fogginess in the brain. Like people would come to me and say, doc, I feel foggy. Like I cannot concentrate. Erectile dysfunction, sperm dysfunction, sexual dysfunction. It's very hard to treat. Not all patients on finasteride will develop this, but I'm very, very reluctant to order finasteride for healthier, younger guys trying to conceive or who are very, very active, just because of this small post-finasteride syndrome. I think it's a syndrome that everyone should read. Even with lower dosage for hair loss, I have a lot of male patients coming to my clinic, like, we're taking finasteride for hair loss. I was like, dude, try to stop it, at least while trying to conceive, or at least like, if I feel like it's giving them any side effect whatsoever, I just advise them to just stop.
Does that affect the sperm or the erectile function?
Both. It's affecting everything. We don't know the exact mechanism of it, and there is actually a big class suit action against finasteride. There is like a major blogs about people suffering with depression, and it's not a medication that has to be taken lightly.
Are there any other commonly prescribed medications that are affecting sperm or erectile function that people might not be aware of?
So blood pressure medication are especially beta blockers. So they would affect the ability for erection to happen. But again, it's a risk and benefit. So is it beneficial for the patient to stop this medication to give them a better erection? Or should we talk with their primary care cardiologist to start to switch from a different family of drugs and give them some medication like Viagra and Cialis to help them with the erection and get both at the same time? So it's usually a collaboration between the patient and the different medical team taking care of this patient.
Are there any sort of side effects or problems with using Viagra and Cialis?
Every medication has some side effect. There is no free lunch. Like whatever medication you're taking, it will give you some side effect. It all depends on what's the likelihood of these side effects. So we have some absolute contraindication for these medications. People who are taking other medication like nitrates for their heart, they have a heart attack or heart problem, and they're taking these sublingual nitrates. If you do that and you take Viagra, they're going to have a massive heart attack that's going to kill them. So there's like a big red flag. Anytime you prescribe Viagra or Cialis, you have to check the other medication. You have other relative contraindication, medication that would affect blood pressure. So you have to be careful with that, because what Viagra and Cialis would do, they're going to dilate the veins, not only of the penis, but throughout your body. So this is also true for the heart. So if you dilate the vein enough and you're not getting blood supply to the coronary artery of the heart, you're risking having a heart attack. So these medication has to be prescribed in a very professional way. They have to see a provider, they have to review your medical problems, and then look at your medication that you're taking. And we have a special guideline on when to prescribe it, how much to prescribe it. So this is from a medical perspective. From a psychological perspective, a lot of younger male population taking these drug to help them with erection start to develop some dependence on it. So for a person to have an erection, you need three elements. You need a good vascular system. You need to bring blood to the penis to dilate the tissues there. You need a good nervous system. You need an impulse coming from your brain down your spinal cord to tell the penis, hey, I want an erection, I want to keep it. But then there's also the psychogenic element, which is as important as the vascular and the neurogenic. If your subconscious is not comfortable with the idea of erection, if it's not correlating erection and sex with pleasure, it's going to inhibit the whole process. Like no matter what you do, you're not going to be able to have an erection, right? So, and then this is why we have a lot of sexual therapists and sex therapy and people who would just go and dig deep into the subconscious of patients to see, is there a component of psychogenic erectile dysfunction, which most younger population have. Like younger population without diabetes or hypertension should have no reason on why they're not having a good erection. There's also, what's left is this psychogenic element. Like it's either performance anxiety, they're trying to please the partner, or bad trauma from their childhood, or like bad experience. Again, something in the subconscious that's correlating sex with something that's not pleasurable. And then we have to work together to break the cycle.
Right. So in that scenario, Viagra and Cialis isn't going to be the answer?
It's part of the answer, but it's not the answer. Like the worst thing you can do is get these young patients, and tell them, you know what, take Viagra and then go. I'll see you in a year. This is very bad. You just have to try to understand why this is happening, where is it coming from, refer them to sex therapists, talk to them about the problem so they're aware, and then try to give them a regimen that they won't be dependent on in the future. Usually, the best thing we can do now is to give these medication as daily dose. So rather than taking Viagra or Cialis as needed, like let's say they want to have sex tonight, 2 hours before they pop the pill and they're ready, we give them a very small dose every day. So they wake up in the morning, they take this 5 milligram Cialis and they forget about it. So this way, their brain is not correlating the pill with performance. And then we give them for a couple of months, and then we start weaning them. So the next time you see them in a couple of months, you tell them, okay, rather than taking it every day, take it every other day for 4 months, twice a week, once a week. And then once you prove to your subconscious that I'm able to perform, this is pleasure, I'm happy, then you won't need anything.
Right. Yeah, and just in case people think we've gone off on a completely different path here,
we did.
We did in some respects, but for if we're thinking about conceiving, right, being able to have and maintain an erection,
correct,
is going to be important. Presumably, there are men who are fertile but can't conceive,
correct,
because they have this erectile dysfunction.
And then closing the loop on this subject, most men coming and dealing with male infertility have some problem with erectile dysfunction because they're putting so much pressure on themselves and their subconscious that they're not providing and they're not performing. So a lot of men with bad semen parameters, when you dig deep and you ask them more, it's like, yeah, we have some problem with erection because it's more of a mechanical problem. Like for a couple to conceive naturally, it's a very, very calculated timeline. There is no randomness. There is no natural way of doing it. There is a specific time of the cycle called a fertile window. So the fertile window consists of 2 days before ovulation, the day before ovulation, the day of ovulation, and the day after. So these are 4 days during the cycle of a female.
Can you say that again? I'm going
to say it again. It's super complicated.
I'm preparing.
Okay. So a couple and a woman should track their ovulation, right? Once you know the ovulation day, they need to have intercourse 2 days before, the day before, the day of ovulation, and 1 day after. So these are 4 days of so -2, -1, day 0, which is the ovulation.
2 days before, all the way through to 1 day after.
Correct. And the idea is you need to give your sperm a head start to reach the egg before the egg is released. So the sperm has to swim from, again, the vagina to the cervix to the uterus
2
to
days?
the tube.
That's how long it can take?
And that.
Wow.
And the sperm can survive up to 5 days inside of a woman's reproductive system. The egg would survive 24 hours. So you want the bulk of the sperm to go there and then wait. And once the egg is released, they can attack it and then fertilize it along the way.
Okay, so if you know that ovulation day,
Correct.
and then we know that sperm life cycle is 72 days,
Correct.
but you said sometimes it might take 2 cycles, so
Correct.
let's say 6 months.
Yeah.
I mean, we're getting very granular here,
Yeah.
but let's just say 6 months out, you're improving your lifestyle, doing all these things we've spoken about. You work out ovulation day, and you're saying that you'd want to have intercourse from 2 days before ovulation day, each day, all the way through to 1 day
Once a day.
Once a
Correct.
day through to 1 day after.
Correct.
This may be a silly question, but leading up to the 2 days before, there's this whole idea again online of semen retention
Correct.
and no
It's
fap.
called an abstinence period.
Right. So what am I doing in the lead up? Am I having sex or masturbating in the week or days leading up to that? Or am I trying to build up as much volume as possible?
This is a great question. I get it every time. So to make it even more complex, so other than these 4 days, a man or individual should abstain from ejaculation, either masturbation or sex, for 3 to 4 days before that. So you have these 4 days.
3 to 4 days.
And then let's say 4 days before that, you should not ejaculate either by masturbation or sex. You should not do it for longer, because if I have patients who come in and say, you know what, we've been abstaining, we haven't done any ejaculation for the past month, extremely bad. Because what happens is they're going to accumulate a lot of toxins and bad cells that are going to affect negatively the sperm quality. So abstaining for a long period of time is very, very bad.
So why is there this idea online that semen retention or no fap is like going to increase testosterone and be better?
No, just a myth.
It's a myth.
It's 100% complete myth. Again, retaining sperm has nothing to do with testosterone. Again, testosterone is just the fuel of the sperm. If you retain sperm for 3 months, your body's gonna start by killing the sperm. It's like having a vasectomy. So you're not ejaculating sperm from the testicle. What happens is your body's gonna sense an overload of sperm in the testicle, and they're gonna start killing the sperm. If you abstain for less, let's say you ejaculate the day before these 4 days, you're gonna deplete the reserve. So you're not gonna have enough reserve, enough sperm to swim up.
Right. So before the 4-day period where you're having intercourse every day for 4 days,
Correct.
You want to go into that with as much volume as possible.
Correct.
Which you're saying you'll achieve that with having just 3 or 4 days of abstinence.
3 or 4 days of abstinence.
Before that day one.
100%. This is the golden number. Not more, not less.
Okay.
So this is why, just to say, I'm saying all of this just to say it's a lot of pressure on the man to deliver.
Right, you need to get the calendar out.
You have to get and this is what I tell my patient. Like, you need to go and buy a calendar. You need to have it on your fridge, and you need to mark the ovulation day for you to know the 2 days before, the day of ovulation, day after. You need to know when to abstain and when to stop ejaculating. And if you do all of this, and you don't have any problem, and your partner doesn't have any problem, the success rate of natural conception is 15% per cycle, 1-5. And this number is set by nature. You cannot improve this number. This is why most couples are going to need a year to a year and a half to actually successfully conceive, which is, again, puts a lot of pressure, because you hear all of these stories. Yeah, we tried from 1 cycle, we got pregnant. We weren't even trying, we got pregnant. These are the exceptions. Most couples are just being very, very patient, doing it in a very mathematical, calculated way. When should we have it? When are these days? And this put a lot of pressure on the man to perform sexually. This is why, going back to our point, a lot of men who are dealing with fertility or trying to conceive, they feel pressure. This is not a natural way to have sex. They have to deliver during these 4 days. Like, the wife or the partner is putting a lot of pressure. Like, it's going to happen tonight.
Right, it
for the next 4 nights.
feels very contrived.
It is.
Less spontaneous.
It is.
Less romantic.
I know.
But what you're saying is you're going to
outcomes-
increase your chances of conceiving if you take a more calculated approach.
It's not increasing it. This is the only way to naturally conceive. If you do anything other than that, This 15% goes down to almost zero.
Right. When I say increase your chance, I mean that if you're not focused on this, you may well be trying outside of this window,
But
as opposed to
the chances of you being successful and naturally conceiving are going to be almost null.
right.
So if you're trying to conceive, this is the format.
This is it. This is the format. Right.
If you have sex every single day of the month, but you skip these 4 days, it's not trying to conceive.
Okay. So just to summarize, to make sure that I've heard this right, let's pretend that the day of ovulation is the 10th on the month. Essentially, on the 4th of that month, you would abstain. That's
Correct.
when you would stop masturbating or having intercourse, any ejaculation.
Correct.
And then on the 8th of that month is when you would have intercourse. You'd have intercourse again once on the 9th, on the 10th, and on the 11th.
That's it. Success rates 15% per cycle. And these are independent probabilities. So every cycle that you're going to try, it resets to 15. It does not add up. It resets to 15. And this is why the definition of fertility was, and still is, inability to conceive over 12 months, over a year. You have to try and try and try for this process to happen.
Fertility aside, is this kind of idea of ejaculating at least once every 5 days, is that generally like a pretty good rule of thumb?
It's excellent. It's like you need to release pressure from the prostate, fluid, and you need to release sperm. So every single day, you have millions and millions of sperm being produced inside of the testicle. You need to help your body to get rid of this, because not ejaculating, retaining sperm and retaining seminal fluids and prostatic fluids are going to increase the chances of having inflammation and problem like prostatitis, orchitis, chronic pain, all sort of dysfunction in there. So this idea of let's retain is actually counterproductive from a medical perspective. Patients who come to my clinic, I'll say, you have to ejaculate an average of 2 to 3 times a week, whether masturbation or sex, any form of, you need to release these fluid and cells to the outside body.
Yeah, I think the semen retention, no fap kind of trend, a lot of that presumably or probably comes back to this idea that it's a masculine trait to be disciplined.
Correct.
To exhibit control.
Correct. If you can control yourself and your sexual desire, you're a better, more masculine, more virile man, which is not true.
Okay. So that's a myth busted. You mentioned exercise before, resistance training, cardio, particularly resistance training can improve testosterone, which is going to have this flow-on effect to sperm health. What about other exercises like specific pelvic floor exercises? You know, when I mentioned to my community that I was going to have a special guest on, a urologist, to talk about this topic, there were a number of people that asked about pelvic floor exercises, things like Kegels. Do these affect male fertility?
They don't affect male fertility. They affect the urinary health. Like, again, every man has this organ called the prostate gland, which sits below the bladder, around the urethra that you pee from. The natural progression of this gland is it's going to get larger and larger with aging. And this is why most individuals with the prostate are going to suffer from urine problem. They're waking up at night to urinate. The stream is weaker. They're like just not emptying their bladder. So pelvic health is important for that. It's just to keep the prostate healthy and the bladder healthy. Kegel exercises are not directly related to fertility. They're just more related to urinary health, BPH, bladder health. So having a good pelvic floor support is going to prevent these conditions like prostatitis or inflammation of the prostate from happening. And this might indirect, like if you have any infection or inflammation in your pelvis, this might negatively affect sperm production and fertility, right? Because you have cells, inflammatory cells, and all of these processes going on that's going to be detrimental for sperm. But then pelvic floor by itself is not related to fertility. It just make the whole pelvic organs and reproductive organs in a better state, and this is helpful for fertility.
Okay, we spoke about nutrition, important isolated nutrients and dietary pattern, exercise. We haven't spoken about sleep. Is there much evidence out there looking at like sleep quality or quantity and how that can affect male fertility?
Very important. So we have a body of evidence showing that an average of 7 to 8 hours of sleep is the magic number. So people have to get a good sleep habit and a good quality of sleep. This is important for sperm itself, like for sperm production, for the quality of sperm, but also for testosterone. So testosterone is the type of hormone that follows a circadian rhythm. So it follows like something that has to do with day and night, like the biological clock in your body. So if you don't get enough sleep, it's going to affect the actual sperm, but also it's going to decrease the level of testosterone, which is decreasing the fuel for sperm production. So sleep is super important. Again, the average is 7 to 8 hours.
Which then can be like almost a negative feedback loop.
Correct.
Because I think low testosterone can then affect sleep.
Correct.
Right?
Correct. So it's like a feedback loop. Like if you sleep well, you're going to have a healthy level of testosterone and sperm, and this is going to you're going to sleep well more and more. And if you don't sleep well, your testosterone is going to be disturbed, and then this is going to negatively affect further the sleep pattern.
Let's talk a little bit more about the medical kind of interventions that you would use clinically. Mm-hmm. So let's say you have a patient come in, you do all the blood tests, and you look at testosterone and estrogen and FSH and LH, and you look at the sperm parameters, and you maybe they've tried some lifestyle changes, they're not quite where you want them. What are the most common kind of medical interventions or medicines that you would prescribe in your clinic? So
when you have a patient in your clinic, you are always looking for a correctable cause of male infertility. So you do a semen parameters, and you have abnormal numbers. You're going to try to understand why these numbers are lower than the reference range, and then you have to find a reason to correct. Around 60% of the time, we are able to do that. Around 40% of the time, we call it unexplained infertility. We don't know why these numbers are
40%.
Around 40 to 30%. Yeah. So in around 60%, usually it's either a varicocele, which is the most common correctable cause of infertility, are these veins. And the way you correct them is you do surgery. Like you go in under a surgical microscope, use a tie, and then you just tie them.
So the veins are... How are they dysfunctional in that case?
Every organ has some arteries bringing blood into the organ, similar with the testicle, and then some veins taking the blood from the organ away back to the body. So specifically, some people, which is a super common condition, 1/3 of men around the world have the varicocele. So if I do a physical exam on 100 men, 1/3 of them are going to have this condition called varicocele.
Is that varicose veins? Is that the same thing?
It's different. So varicose veins are these varicose veins in the legs usually. These are called varicocele. They're basically dilation of the veins of the testicle itself, specifically the testicle, because of inefficient valve. So the blood is coming back up, but the valve is not efficient in closing down. So it's leaking some blood back around the testicle.
And that's affecting the temperature?
Correct. So it's affecting the temperature of the testicle. It's also affecting something called oxidative stress. So within the sperm production, there are all of these bad cells, oxidative stress, and cells in there. So having more blood not going back to the body are going to affect sperm production and increase the temperature.
And would a man be aware of that just by observing their testicles or their temperature?
It can be, because within the varicocele, we have 3 stages. We have 1, 2, or 3. Stage 3 is what we call a bag of worm. It's like you look down there and they're like, it's a bag of spaghetti. It's like a lot of dilated veins, which looks abnormal. Usually it happens on the left side. So around the left testicle, there would be what we call a bag of worm or a spaghetti bag. It's like just like these small veins that are very, very abnormal in number compared to the right side. So once we have this condition, again, 50% of those men will have some problem with their fertility. The other 50%, they have no problem. We don't know why. So a lot of men have this condition. I have a lot of patients just coming to see me because of this varicocele. It's either detected when they did the ultrasound or they were doing these self-examination and they felt something wrong. And I tell them, you know what? You have a varicocele, your semen analysis is normal, don't worry about it, just go. So once you have this condition and you establish that this varicocele is affecting the sperm, you can fix it surgically. You can just tie these veins and cut the blood supply. And there are some caroterism, other mechanisms to drain the blood from the testicle back. And you have a major improvement in the parameters. You should not forget that this is a time-lagging process. So you do the surgery today, I get them back in around 6 months, do another semen analysis to check any improvement. So this is number one. Number two, the other factor that might affect fertility are hormone imbalances. So if you do a test and you check the testosterone and it's low, you have to correct testosterone. You have to correct the level of the fuel, right?
Is there an optimal total or free testosterone you like to see?
So the normal total testosterone is around anything more than 250 to 300 would be good. Anything more than 35 free testosterone is also good. So if you have someone around the 50 free testosterone, they should be okay. And then the way to improve the testosterone medically is never by giving them testosterone, because again, it's like counterproductive. You should never ever. Down. It's going to shut down the productive. So what you do is you use these medications like clomiphene citrate or ACG to tell the testicles to send signal to the testicle and tell them, hey, we want more production, wake up.
Right. So you're just essentially kickstarting that natural testosterone production, which, as you mentioned earlier, will then affect sperm production.
Correct. The other part is if you have patients with azoospermia, like they come in and they have no sperm, and you do all of these tests and everything checks out, there is nothing normal. One of the solution is to go to the testicle itself and then take tissues from the testicle to get and isolate sperm. And this sperm can be used for IVF. You can take one sperm, give it to the IVF people, and they can use the sperm to fertilize an egg.
So they might have the sperm in the testicle,
in
but
a
it's
very,
just
very
not,
low concentration.
It's just not coming through.
So either it's not coming through, which a condition that we call obstructive azoospermia, or the actual factory is not producing enough sperm that would go into the ejaculate. So you go to the factory itself, you open it up, and then you take a little bit of tissues and give it to the technician, and the technician would be like looking for a stick in a hay. It's a very, very small cell, and they would be looking and either telling us we need more tissue, and then you take more tissue and give it to them. Or if it's an obstructive, best case scenario, you have millions of sperm stuck in there. You take a small tissue, you give it, you have millions of sperm, and you can use it for IVF. So this, again, around 60 or 70% of the time, we are able to identify a reason, a medical reason. We are able to correct it with either medication or surgery. And the outcome is we can provide sperm for either IVF or natural conception. Around 30% or a bit less, we're still trying to figure out why this is happening. It goes back down to some genetic and epigenetics. So people have inherited genes from their father and grandfather on their Y chromosome, making the production inefficient. Like you go in there is no sperm.
Are there any kind of latest advancements or areas of science that you're particularly excited about or kind of keeping your eye on that you think might help you with that 30-40% of patients that you can't treat?
Unfortunately, unlike IVF, which is a multi-billion-dollar industry, male fertility is just a relatively new domain. Like over the last 50 years, we haven't had a single improvement or a single new medication or even an FDA-approved medication to help with male fertility. And this is because IVF has acted as a way to overcome male fertility. People are not interested, or we're not interested to treat and to figure out male fertility. Once we give them sperm, that's it. Our job is done. The male job is done. They can use the sperm for IVF to inject it into an egg. Nowadays, with more awareness, more education, podcasts like these, people are more interested in figuring out why there might be a problem. So more money are getting into the field. And this is what I like to do. I like to bridge the academic work. Like I work at a hospital as an urologist and male fertility specialist, but I'm the chief medical officer of a startup company. So you have the money, you have the academic, you have the research, and trying to bridge all of this together is what's going to drive the field forward. So a company like Legacy are investing a lot of money in the research around sperm and male fertility, and they're giving this money because the money is in the industry, it's not the academic place, right? So all of these investment are, part of them is going to the R&D. And I think this is what's driving the field forward. The most exciting work is around the genetic and the epigenetic, to understand how can we understand better the DNA of the sperm, and is there a way to go in there and try to kickstart sperm production that's not there. This is one part. Another part is using AI into a better assessment. Let's say you're doing a surgery and then visually you cannot see the sperm. You have these AI algorithms that can detect and tell the technician, hey, there is a sperm hidden somewhere there. So it has like a way more efficient way of detecting sperm. So there are like some cool technologies going in there. But again, the bulk of advancement is mostly around IVF. It's basically getting the best sperm to be injected into the egg, or trying to figure out when to do it and how to do it, and when to transfer the embryo back into the woman. So it's a lot of money going into the IVF versus newer interest in the male fertility.
Mm-hmm. And breaking down some of these barriers that exist that are no doubt stopping many men, or kind of getting in the way of men coming to see people like you in clinic.
Correct.
You know, and you only have to go online to see that this space is kind of rife with bro science.
Yeah.
And you've sat here, and this has been a masterclass display of, I think you said 14 years of study.
Correct.
Right? And so it would be silly to think that you can kind of just solve all of these things on your own online and cover one compound with another, which, you know, tends to happen in this space.
And then it's a very, very exciting space, not because I'm working on it, because we're trying to understand more and more that the fertility space, semen parameters, are not only related to fertility, right? It's a marker of general health. And this is, I think, what's driving more and more the field and the investment in the study, because a lot of major research coming from a European country and a great mentor like Dr. Eisenberg at Yale are showing that people with low semen parameters, or men dealing with male infertility, have a higher risk in the future of developing chronic diseases like hypertension, diabetes, stroke. People who used IVF as a method for conception have a higher mortality rate, and they're being admitted to the hospital more and more 50 years down the line. So actually, a lot of physicians, including myself, we think as sperm as 6 vital signs. Like you have blood pressure, heart rate, temperature, all of these factors. But then you can test the sperm at some point, hopefully in the future, and I can predict the likelihood of you developing diabetes or hypertension. And once you know that, you can have an early intervention. Like I can tell you, you have an X% high risk of having a stroke in your 50s because your semen parameters are low now. And then you can change your lifestyle. You can get on medication earlier to prevent this. So sperm is not only about fertility and having kids and like just the whole fertility. Sperm is just a window that would look at your future health. And I think this is what interests people now. Like we have a way, because sperm is a germ cell. Like it's the one cell that has this, most cells start with. It's like a stem cell of your body, right? And again, if you think about the body as a holistic organ, if you have a stem cell that's showing dysfunction, you're going to have dysfunction in other organs. And now we have proof. We have actual studies giving us a 2.5 high risk of mortality rate for people for men using IVF, a 10%, I think, increased risk of diabetes and hypertension later on in life, which is very, very interesting, at least for me, to know that, because people would have a better time dealing with sperm and talking about sperm, because it's not only fertility, it's future health, but it's also current health. Like, a lot of men coming to my clinic have been detected with testicular cancer. Like, when you do physical exam, you can detect some organs. Like, if I do a blood test and I see a high prolactin, then we do an MRI of the brain, and some men are diagnosed with pituitary adenoma, like a benign growth in their brain, and they get treated for. So again, this is a way that would get more men into the clinic. So with female, it's a bit easier because they have the yearly pap smear, and they get pregnant, and they have like more tendency to go see their patient. For men, there's no OBGYN. Like, our CEO, Khaled Ktaili, has invented this term OBGYN. Like, we need to push more men to go see providers, because once they do that, we can detect, we can make them healthier. And sperm can be the start. Like, if you have easy access to a sperm and there is a dysfunction, then you go see a provider, then this provider will do physical exam and lab work, and it can save you from testicular cancer, or like a brain tumor, or stuff like that. And it can predict, hopefully in the near future, your future health. So it's like, it's a journey.
So in that sense, is it something that you think men should be doing annually? And at what age, and when do you stop doing that? Is there a certain age where you no longer need to be considering your sperm health?
That's a good question. We don't have, like, I cannot give you guidelines. Like, I'll be not scientific if I tell you, like, I have to do it every 6 months for a year or for 10 years. I'm just saying that testing your sperm has a lot of potential. There are a lot of questions right now that we don't have answers to, but it's a very exciting field, because we have evidence that sperm has more to do than fertility. It has a lot of other function.
And is it, if you're thinking about sperm as a kind of window into your overall health risk or your health span, is the biomarker, are we coming back to that volume by concentration by motility? Is that
correct?
Is that the biomarker?
It's basically a biomarker of, it's a sixth vital sign. It's like, if you have this number that's around the reference range, you should be kind of protected from these high risk in the future. If you have a lower total motile sperm count, then not only your fertility might be affected, but some other conditions and processes in your body.
And just to remind people, that was more than 20 million.
Correct.
That you're looking for total.
It's a product of volume, concentration, and motility, and it should be around 20 million or more.
You mentioned cancer, and that gets me thinking about people that have undergone chemotherapy or radiation. Do you have patients coming in to see you that have had cancer, have gone through chemotherapy and or radiation, and have questions about their fertility?
This is one of the areas in May Fertility with a lot of improvement, because people are aware for quite some time now that any adjuvant therapy for cancer, meaning that any treatment after diagnosing cancer and treating it, like chemotherapy, radiotherapy, immunotherapy, will affect sperm no matter what. And this could be a reversible or irreversible condition. Like, people taking, let's say for testicular cancer, getting chemotherapy or radiotherapy might have an irreversible sperm damage. They might not have sperm after their treatment for some time. So there is a field in urology called oncofertility, like fertility for oncology patients, whereby any patient with any type of cancer who are trying to conceive, or within the age group of, let's say, 20 or 40, or any interested in fatherhood or biological kids in the future, we have to send them to freeze their sperm, and we have to educate them that you're going to get this X surgery or this X treatment, and this is going to affect your fertility potential. So we have to preserve that before doing anything for cancer. Like, your survival is very important. We have to make sure that we're giving you the best option for biological family and the fertility potential in the future by basically freezing sperm. So there is this category of patient with high risk, higher medical risk. There are also the other category of military firefighters or patients that are working in a very intense job who are at high risk of getting injured or like being exposed to bad material around them or environmental exposure. These are another group of patients or individual who should be thinking about sperm freezing. Like if you're a military being deployed, exposed to burn pits or like having some problem in the future, freezing sperm is a good idea. Firefighters, policemen, all of these high risk job where the risk of injury to the testicle or exposure is high, again, they should be thinking about sperm freezing and preservation.
I just remembered a story, and it's quite a sad story actually, but I wonder if you've come across this in clinic where a guy passed away and he'd written in his will, he'd given approval to his family for his semen to be extracted within like a 24-hour period, I think, of passing away. And then his partner went on to have his child.
I know.
Have you seen that?
We haven't seen it personally, but we've heard of it. Very similar stories whereby it's a very complex process. Like the whole fertility and male fertility and sperm freezing is not straightforward. It's very different from you having a heart attack, putting a stent, and you go on to live with your life. It has to do with ethics, with society, with family, with relationship, a lot of legal issues. So when we face these type of conditions or situation, we have to go to the ethical and legal department in my hospital. Like, hey, I have this, what should I do? Because you need to protect yourself and you need to do what's best for the deceased patient and their family and their wife. So it's very, very complex. But just to say that it's complex, but it's interesting. It's good to deal with it. It gives you a lot of satisfaction to be helping these patients and these families to go through a very, very emotionally complex journey. Like it's like a roller coaster. Like they come in, they're depressed, they're sad, you help them, they're happy, or they trust you, you figure out different problems, other problems, you treat them, you save their lives. So it's a very rewarding part of medicine.
Yeah, you're right. There is certainly a lot of ethical implications. Yeah. I have a friend who always says agreements prevent disagreements. This is one of these areas where it's probably good to write things down.
He's a wise friend. Should keep him around.
I need to let you get back to Ohio. This has been a masterclass. Thank you very much.
Thank you so much for having me. I'm always very excited to be in those podcasts because increasing awareness and helping people understand, giving them information they can digest is just the first step along their journey. And then hopefully this will push them to take ownership of their health in general and fertility health. So thank you for having me.
You're welcome. One last question. We hit a couple of myths. We hit the myth about nofap and semen retention. Are there any other myths in this space, things that come to you in clinic that you just want to clear the record on?
I think we touched upon this a little bit earlier. Fertility is not a female problem. This is like a biggest myth among society and men. Like, don't try to blame fertility problem and inability to conceive on the female. We've seen a lot of couples who come in with 2 or 3 years of the female trying to do their testing and try to conceive and the male partner has never ever tested their sperm. So the biggest myth I want to make sure that people get is men are 50% of the problem and they should be 50% of the solution. Like half of the time it's a problem with the male, and people should be aware and they should overcome all of this misconception and myth and the thing they have in their mind from their past experiences or from their friend. Take ownership and have the courage to go educate themselves, read more, and go to specific places with healthcare provider and specialty clinic to start their journey there.
Thanks, Dr. Ramy. It's been a pleasure.
Thank you for having me. Thank you.
There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.